It's great to be here this morning, and the first thing I need to do is give a shout out to my Wahoos on their victory yesterday. Wahoo! So this morning, what I'm hoping to do in our time together, I'm really here today wearing the hat as the chair of our Faculty Vitality and Physician Wellbeing Committee here at Crillian Clinic and VTC. Many of you may not know that committee existed. It actually has existed in some form or another for the last almost 4 years. And we reorganized the committee back in November of this year. And in reorganizing it, what we did is we brought what I call a representation model to the committee, which means that all the clinical departments have representatives coming to this particular committee. In internal medicine, that those representatives are Elvis Pagan and Kim Matthews. In family medicine, it's Beth Polk and Laura Daniels. And so as you have questions about some of what I'm going to be talking about, what I would encourage you to do is channel those through your representatives on the committee, because what we're trying to do is open a conversation throughout the organization about what I consider and many consider a very important topic, and that is physician well-being and in particular physician burnout and what we can begin to do about that. My hope this morning is to do a few things with you. One is that I'm hoping to perhaps for some of you reframe your thinking a little bit in terms of this whole idea of well-being, professional well-being and what it's about. For some of you, I'm hoping that our time together may recharge your spirit a little bit, depending on where you find yourself right now along the well-being continuum that we'll talk about in a moment. And for all of you, I hope that I'm able to plant a little bit of the seeds of possibility about what could be both for your own professional life and also for our organizational and medical school life in terms of the kind of culture we want to have here at Crillian Clinic and BTC. When you think about the practice of medicine, I consider it an incredible privilege to be a physician. The practice of medicine is rewarding. The practice of medicine can have deep meaning and fulfillment when one pursues it in a way that really stands for the best of our qualities in medicine. On the other hand, the practice of medicine can sometimes be very mundane, can sometimes be very tedious, and can be often emotionally exhausting. And so what would it take for you to truly say, I love my work? Now, some of you sitting here right now would say, well, I do. So I've answered that question. Now, for you, I would say, stay anyway. All right? Because whatever you're doing, many others in this room need. And so you are some people we can look at as exemplars to be able to say, what are you doing that we need to learn from? For the rest of you, my hope is as we travel this journey together in the next 45 minutes or so together, you'll begin thinking differently about what that might take. Because some of you may look at that question and say, couldn't happen. Or some of you who said, the way I decided to figure out how to love my work is I soldiered through and then I did this thing called retirement. And that's when I fell in love with my work, looking backwards. Oh, it was great. It was great. Right? What would it take? So, by way of disclosure, I do love my work. But that wasn't always the case. In 2001, after spending what I now understand was a year in a combination of grief and burnout, I sought help. I reached out to some colleagues after having not done that for the entire year and realized on my own I wasn't going to be able to do that. And I was not enjoying medicine at all. I had completely lost my spirit, my enthusiasm for this work that we all have invested such a great amount of time in. By reaching out to colleagues, by doing some of my own personal work, I recovered that particular spark of professional enthusiasm. And one of the things I vowed to do at that time, and have been in the conversation since, is I said, I want to take some of the lessons that I learned, and by whatever mechanism I have, whether it be medical education or whether it be other things, and now I've had the opportunity to do that all over the country, to begin to talk about what we can do to advance professional well-being in this important work that we do. So why are we here? These are some objectives of some things that we're going to cover today together. We're going to be talking about what I call the burnout to thriving continuum and beginning to think a little bit about well-being. Well-being is not just whether somebody is burned out or not. There's a whole lot more to it, and I want to plant that seed with you today. Talk a little bit about national data and our local data in the context of how we're doing as a profession. And then finally, talk a little bit about a framework that we're using within the Faculty Vitality and Physician Wellbeing Committee that we're hoping that we can use throughout all of our clinical departments to begin to think about this very important topic in a little bit of a different way. Before I do that, I want to check in with you all. It is early in the morning. Some of you have already been up and rounded. Some of you rolled out of bed for the first time at 7:30 in a long time because this is Friday and you came to Grand Rounds and you didn't get to sleep in. But I want to just check in with you to make sure that we optimize your ability to be here this morning and be present during this time that we have together. And in order to do that, I use an acronym that I call ENOUGH. And ENOUGH stands for energy, openness, and focus. So let's do a little check-in. First, around energy, here's what I'd like you to do very quickly. Just look around and fist pump 5 people and say, I'm glad you're here this morning. So go ahead and please do that. Now, for some of you, that alone was worth the price of coming here this morning, all right? You needed that. So a little energy. Energy is very important in terms of our ability to both learn and in terms of our ability to thrive. How about openness? I'm going to put just a picture up here on the board, and I want you to just say what you see. All right? Very simple. Nothing tricky about it at all. Here it is. What do you see? Okay, somebody said a bunch of lines. Somebody said an E. How many of y'all see an E? All right, for those of you who don't, now look. Anybody who doesn't see an E? All right, here's the thing about this. There's no E up there. I promise you, that's just a bunch of lines at right angles to each other. All right? Sometimes we see things that aren't there, but they certainly seem like they're there. So openness this morning. I want you to be open to being able to see things that perhaps you hadn't seen before. Finally, focus. We did our letters now, so you had a little warm-up. I'm going to put just a sentence up on the board, and I'd ask you to just read it out loud. Okay? I'm sorry. Sorry. Different sentence. I'd ask you to read it to yourself. And what I want you to do in reading it to yourself is count how many of the letter F there are in this sentence. Simple. Okay? Here we go. Focus is very important. By show of hands, how many see 7 F's up there? Good. How many see 3? Raise them high and proud. How many see 4? How many see 5? How many see 6? Now, I just want us to stop for a minute and think about the cumulative education of this group in this room right now. Okay? The alphabet now is a preschool activity. All right? There are, in fact, 7 F's up on the screen right now. Why did this happen? This happened for a very simple reason, because your brain, for those who didn't see 6, tricked you. And every time you saw the word of, you heard the sound V even as you saw the letter F, and your brain said, no F there. All right? Focus this morning. Why are you here? One of the things that I've learned over the last few years in the context of both my learning and my life is the importance of being deliberate about the work that we do. Call that setting an intention. I actually learned this in the context of intention about 5 years ago. We celebrate in our house, we celebrate Christmas, and my wife wanted one thing for Christmas. She said, I'd like a year of yoga classes. Now, my wife had never done yoga before. We never talked about it before. I was kind of spooked out by the whole idea of yoga. And so she said, I said, okay, fine. So I got her a year of yoga classes. And then she said, as her second request, I'd like you to come with me. Yeah, exactly. And that's what I thought. Okay, I love you. Yeah, this is what love is all about. So I went with her. Now, here's the irony of what happened. I fell in love with yoga. She liked it very much, but she didn't like the class because she felt like she was too vulnerable there. And so she bought videos and started doing it at home. I continued to do it. One of the things that happens, for those of you who ever practiced yoga, is at the start of the class, the instructor will say something very simple. They will say, before we get started, I'd like you to set an intention for your practice. I thought, what? It's become very powerful for me to become very conscious and very explicit about Why am I here, and what is it that I hope to accomplish? So thinking about, why did I show up this morning? What is my intention? What do I hope to get out of this time that we're here together, investing life energy, 45 minutes of it, as part of our time? And in doing that, I want you to think about three things. I want you to think about, as we talk this morning, what are some things that are highlights for you? Just something that stands out for you. Wow, that's important. I like the fist pump thing. Let's do it more often. Okay? Insights, something that you say, aha, note to self. I need to remember that. That is important to me. And finally, at the end, I'm going to challenge you to say, so what? So we've spent this time together. What are you going to do differently because of the fact that we've spent our time together here this morning? So here's my first question. It's not a trick one. How are you? On a continuum from burnout to survival to fine to well to thriving, where would you self-assess yourself this morning? We're not going to do it by show of hands, just an honest question for yourself. Where am I on this continuum? If we're honest, many of us would say, I'm here, or I'd love to be here. I'm not even feeling that. I'm feeling run over right now. Okay? Survival is something that's a very interesting concept because if we think about the socialization that we often have in medicine, we're socialized for survival. Look at this textbook. This textbook is in its 5th edition right now, which means there's been many generations of physicians who have been programmed during their 3rd year of medical school to say, how am I going to survive the wards? And that doesn't end. And so that language becomes important language. And sometimes we'll actually hear people saying that. How you doing? I'm surviving. Not as just a statement of fact, but as a badge of honor. I'm surviving. Because think about the alternatives. Okay? Survival. What I want you to begin thinking about today is survival. Survival is maybe a stopping point along the way, but in no way do we want survival to be the place where you practice medicine from. What would it look like to practice medicine from this place? I call this place thriving. There's many other words for it. Flourishing, joy, deep meaning, fulfillment. But Jim Lair, who's the head of the Human Performance Institute for Johnson & Johnson, defines thriving this way. He says it's the state of being physically energized. Any of you all ever felt physically energized in your life? Just by show of hands. All right? Emotionally grounded. Show of hands. Anybody ever been to a place where you felt like, I'm emotionally grounded right now? All right? How about mentally focused? Okay? How about relationally connected? I feel relationally connected in my life. All right. And how about spiritually aligned? All right. So if I do a quick poll, what it seemed is that almost everybody raised their hand for at least one of those. So here's the first seed of possibility that I'd like to plant for you this morning. If you've ever experienced any of these things in your life, ever, you could potentially experience these all the time in your life. There's no reason. You already know the formula for getting there. It's just a matter of how do I do that more consistently. That's what thriving looks like. And what I want to introduce to you this morning is the concept of saying, why wouldn't I want to practice medicine from this place? And if I were a patient, why wouldn't I want my physician or my nurse practitioner or my physician assistant or my nurse to be caring for me from this exact same place? I sure would. One of our colleagues in family medicine, one of our new colleagues, Jonathan Stewart, was just in this hospital. He had, unfortunately, had to have some neurosurgery done because he had a cyst in his brain. Talked to Jonathan yesterday. He's doing very well. And he gave me permission to share this. And he said, what was so amazing, he said, I learned so much about the practice of medicine by being a patient. Now, we hear that all the time. He said, but no. He said, I teach this. He's an educator. He's a medical educator. He said, I never would have had any idea what it's like to be a patient until I was in that room, in that gown, being cared for on the other side. And he said, hospitals are a great place to get the care that you need, and they're a terrible place to recover. So, yeah, what would it look like if we could come from a place of providing care in a place that was thriving? Well, in order to do that, I would contend that we have to name what I would call the elephant in the room, or perhaps the elephant in the exam room. Right? And that elephant, I would contend, we need to begin to look at in a very, very different way. Because right now, we're kind of stuck thinking about this in one fashion. And what's that elephant? Well, the elephant is this well-being continuum. And what I want to do is I want to introduce a roadmap for us to begin thinking about this differently this morning. The first thing is to say, you know what? We're not doing well. And I'm going to show you the data on that in a minute. And so we need to name the fact that we're not doing well as a profession. And we need to make sure in doing that, when people ask for help, we don't shame them, because that's some of our history, and it's a little bit of our dark history. It's a problem. We are not well right now as a profession. Second thing we need to do is we need to claim it. We need to say, this is our problem, and not look outside of healthcare to all the other things that are going on out there that are not always great, and say, if it were only for this, we'd all be well right now. Okay? Those of you with some gray hair know that if it's not this, it's something else. There's always going to be stuff going on out there. And so if we become victims of that, we're not going to be able to address the root causes of what's going on in terms of our professional well-being. Third thing we need to do is we need to frame it. And not proclaim, as some have done nationally, now that burnout has all of a sudden become this really neat thing that everybody's talking about. I know the answer. I know exactly what we need to do. And the fact is that this is a very complex problem. It's a very contextual problem. What we need to do, there are some things that are common across all professions. But what we need to do in family medicine or internal medicine to help address this problem is very different than what we need to do in orthopedic surgery or neurosurgery. Because there's a lot of cultural context and microcultural context to it. And finally, I would say we need to tame it. And in taming it, we need to say, together, let's do something about this, and not disclaim, as sometimes I see happening, where people say, there's not enough evidence to do anything, or we don't know what to do. Okay, and we're going to demonstrate in just a moment. We know some things right now that we can do to begin to address this problem. So name it, claim it, frame it, and tame it. And in doing that, we're going to have what I call our secret weapon, which is the fourth aim. By show of hands, how many of you are familiar with the triple aim of healthcare? It's very important that you understand the triple aim of healthcare, because it is the vision of Carilion Clinic. Carilion Clinic says that we are about the triple aim of healthcare, which is three things. We want to provide better care to individual patients, better health to populations, at a lower cost. That's the triple aim. It was first coined by the Institute of Healthcare Improvement. Better care, better health, lower costs. And what some national folks had said, really highlighted by Tom Bodenheimer and Christine Sinsky in their 2014 article, is that we will never achieve this triple aim of better care, better health, and lower cost unless we look out for the people who are supposed to be delivering on that triple aim, called us. And so they said, what we need is a fourth aim. And this fourth aim says that we need to be sure that we're caring for those who are providing the care as we do this, because the care of the patient requires the care of the provider. So let's name it. It's a problem. Is burnout real? Again, I shared with you that I've experienced it. So for me, it's very real. So let me just ask you this. By show of hands, how many of you all would say you know a colleague that by whatever definition you would use was definitely professionally burned out? Just by show of hands. All right? Here's the irony of burnout and the irony of us as a discipline. When I go around to groups of physicians and I talk to them and I say, how are you doing? Okay, most of us, when somebody asks us how we're doing, we find the middle ground and we say, oh, I'm fine, which is why I put fine in the middle of our burnout continuum. Right? And then I ask them, how are your colleagues doing? And what they invariably tell me is, well, they're fried. I mean, they're just, oh my God, they're just. And then I go to their colleagues and I say, how are you doing? And they say, I'm fine. And I say, how are your colleagues doing? Oh my gosh, they're fried. Right? And so it's very interesting that often we have trouble seeing this thing called burnout. And I'll acknowledge that there's a lot of different concepts of burnout, and we use that phrase in many different ways. How you doing? Well, I'm kind of burned out right now, okay? That's just a descriptor of I'm feeling a little tired, perhaps. But here's the definition that I've come to that I use for burnout that I think really captures this phenomenon quite well. Burnout is a condition that results from the chronic inability to emotionally recover from the distress of work, in downtime. Let me break that down for just a moment. It's a condition. It's not a diagnosis. Okay? There's nothing in DSM-5 about it. Okay? So it's this thing. It's this thing that's a condition. It's chronic. You don't get burned out from one day, one hard day at work. Okay? It comes on over time. And it comes along over time. It's an emotional issue, and it comes on over time because we don't emotionally recover from what? The distress of work, not the stress of work. Okay, there's some things that happen at work that are very stressful perhaps, but in a good way. We call that eustress. Okay? It's the distress of work. And it implies that we don't have time to recover from it, which means in order to recover, we have to have this phenomenon called downtime. And downtime isn't necessarily a 2 or 3 week vacation or sabbatical. Downtime can be a breath that one takes between patients. Okay, but if we don't program that into ourselves, over time, many people will begin to manifest a certain group of symptoms. Christina Maslach, who coined the Maslach Burnout Inventory and has done really a lot of the pioneering research on burnout, says that over time, when this happens, 3 phenomena will begin to occur. One is that we will exhibit emotional exhaustion. We're just spent. We got nothing else. We got nothing to give. We will start to become cynical. Okay? Or we will start to look at our patients as objects rather than human beings, or perhaps impediments to our getting somewhere else, usually getting out of work. And then inefficacy, the sense that the work that we do doesn't matter. It doesn't make a difference. It doesn't have any meaning anymore. And when this starts to happen over time, we describe this, or she describes this, as burnout. She also said that at its core, burnout is an erosion of the soul. And any of you who've experienced burnout yourselves can relate to that. Because the work we do is soul work. And if we don't have anything to give to fellow human beings in their suffering anymore, there's something very empty inside of us that can happen as well. Well, what do we know about this phenomenon? Well, in 2012, Tate Shanafelt and his colleagues at Mayo Clinic published a study, national study, using the Maslach Burnout Inventory, and said, how are we doing as a profession? Because they had good reason to believe we weren't doing so well. By the Maslach Burnout Inventory, which again is one measure, but it's one that has been used nationally in studies, the mean high risk for burnout in 2012 was 46%. You're, of course, trying to strain your eyes to say, where are we on this? Well, I'll make it easy for you. Family medicine was at 51%, internal medicine was at 53%. Now, this doesn't mean 51% were burned out. This means they were considered at high risk for, and likely many were, in this state called burnout. Well, here's what happened. In 2012, this study was published. Most of you probably never knew it existed. Okay? And as I like to say, if this had been airline pilots, there would have been congressional hearings. But this study really got published without much fanfare, and most people who did know about it looked at it, kind of sized it up and said, yeah, 46%. Yeah, it sounds about right. And then we went on doing our work. So Shanafelt and colleagues 3 years later repeated the study again. And at that time they found that the high risk for burnout rate had gone from 46 to 54%. And as you can see by the blue lines, every discipline increased during that time. All right? Again, you're wondering with strained eyes, what about us? What about us? So family medicine, internal medicine continued their upward climb. Well, here there must be something about that 50% point, because this article caught a lot of attention. And this article really catalyzed a lot of the conversation that we're having now around this phenomenon called burnout. What happens, though, when groups of people or organizations encounter threats or challenges that are really difficult to get their heads around? Is there certain phenomena that happen? And when you have a group of people who more than 50% of them are not thriving, that means that there's a lack of adaptive reserve on a general level. This is not an individual problem anymore. This is a systems problem. And often what happens, and what I believe has happened in our own profession, are 3 things. One is that we as physicians, we just haven't talked about it. Okay? We all know of colleagues, or we of ourselves, who have suffered, who have been distressed by the work that we do, and yet we haven't found a place to talk about it. Administrators tend to say, I don't want to hear about it, because if more than 50% of your workforce was fried, what are you going to do? La, 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 la. Let's get back to work. Come on, this is good work. Let's go get them. All right? And payers and patients, they're blind to it. Because if they really knew that many of us were in that much distress, they wouldn't be lining up to say, open up my brain, operate on me today. Okay? And yet they do. And so what can we do about this? Well, the good news is, this is from the National Academy of Medicine back in July of this year, is that national organizations are starting to say, all right, let's start to look at this. Let's start to do research around this. Let's start to understand better what the heck is going on. Whatever we call this thing, we know it's not good, and we know it's negatively impacting the kind of care that we aspire to provide. How can we begin to do this differently? And so how can we claim this? So when we look at this data, the one thing that I can tell you is no one is going to ride in from outside of healthcare and save us. No one is going to look around and say, poor doctors, let's help them. Okay? We just have to accept that as a profession. And so if we're going to solve this, I believe, and many others do, that we're going to have to be part of the solution. We're going to have to begin talking about this and looking at it in a different way. And if you think about the work that we do, of course we're at risk. I mean, why would we not be? The work that we do is intense. And the work that we do is often relentless. And so if we don't have that time to recover, that downtime, of course we're going to be at risk for this. And in the midst of that, one of the things that's happening more and more is that because of the nature of the work that we do and the technology and the pace, we're becoming more and more isolated from each other. We're not talking to each other as much anymore. We're not gathering. We're not doing the kinds of things that generations of our colleagues before us did regularly. And that has a cost, and that takes a toll. What we also know is that under distress, our brains work differently. Our prefrontal cortex and our hippocampus and our amygdala all have consequences of chronic stress. And part of that becomes that we don't think as clearly. And those of you who have been under distress know that all of a sudden your brain, which needs to be precise to make the kinds of decisions that we're making, sometimes gets fuzzy, sometimes gets a bit cloudy. Again, if that's happening, it's happening sometimes, it's understandable. But if that's happening regularly, that's a problem. Here's what we also know, is that the consequences of this are quite real. American College of Physicians just published a guideline that I covered. I do a weekly e-newsletter called Take 3, and I covered it today. It's a fabulous article. It's really about the hidden curriculum in medical education. And it talks about that idea that many of you have experienced, where we set up these incredible ideals for the kind of work that we do, and then you get behind the curtain and you see the way it actually is. And there's sometimes an incredible gap between those ideals and the reality. That's okay, except that it causes great confusion for our learners to say, what do I do? These are my role models, and they're acting this way, and yet I've been taught that this is the way I should aspire to be. How do I come to terms with that? We've likely all experienced that. We've likely all experienced negative role models. Hopefully, for many of us, we learned from them and said, that's not something I will ever do. But that's not always the case. Second victim, moral distress, disruptive colleagues, decision fatigue, compassion fatigue, cynicism. Likely we've experienced that or witnessed it in others. And the consequences are this. The burned out physicians and staff provide burned out physician and staff care. That's just the math. Okay, you can't provide 5 out of 5 care if you're feeling like a 1 or 2 out of 5 clinician. Can't happen. What we also know is this has become a quality, safety, and now an accreditation issue as well. Our ACGME, our LCME, and other organizations are starting to get involved in this and starting to get into the conversation. And yet often this is what happens when we finally sit down with a colleague and say, how are you doing? I think you're really exhibiting burnout. We're tempted to do what we often do because we're socialized to do, is to say, I'm good, I'm fine. I don't need help. Right? And how do we begin to come past that? Well, part of what we did in our own system is to say, in order to really engage in this conversation, we need to begin looking at our own data. And so in 2016, we did a survey here at Curling Clinic. And what we found was we're the national average. Okay? And it wasn't surprising because there wasn't anything we were doing here that was particularly intentional in the context of addressing this particular phenomenon. What we also found is that there's not a lot of data at all on our ACP colleagues, but they were mirroring what everybody else was doing. What we also found was another very interesting phenomenon, because in the study we asked people to self-rate themselves along this continuum from burnout to thriving. And what we found was that it was pretty much of a bell-shaped curve. in terms of how they answered that question. And yet what we know is at the same time, according to the Maslach burnout inventory, 59% of them were at high risk for burnout. And so what's going on there? Is that just optimism? Is that denial? Is that resignation? Or what I think is it's a reframe. That many of us has been living in that space for so long that we've become accepting that this is the way it is. And so if people say, how are you doing? Well, I'm doing the same as I was last year, so I guess I'm doing fine. Fine being kind of that neutral term for I'm living somewhere in the middle. So how are you really? Some of you are thriving today. Some of you likely are burned out or in survival mode. Perhaps a better question would be, how would somebody who experiences you on a regular basis say you're doing? Because likely they would have an opinion. And likely it would be important for you to know if their opinion is different than yours. So frame it. How do we begin framing this? Here's one thing we know, and I love this quote. We're unlikely to resilience our way out of this problem. Okay? A lot of those national people who've come and said, I know what we need to do. It's just about resilience. We just need to bounce back. We just need to be stronger. We need to be tougher. Here's what I know about healthcare people. Here's what I know about most of you. You wouldn't be here if you weren't incredibly resilient. Because you've taken a lot to get here. Right? Now that doesn't mean that resilience isn't important in this process. It's very important because I would contend because of the work we do, we need to be more resilient than other professionals. We need to be able to do that. But resilience in and of itself is not going to solve what many believe is primarily, or at least at its core, a systems problem. So what I don't want anybody leaving here today is thinking, if I'm feeling burned out today, it's because I'm weak. It's because I don't have what it takes. It's not true at all. And you wouldn't be sitting here if that wasn't the case. Here's the other thing that we need to understand is that resilience is not the same thing as well-being or thriving. Okay? A lot of people are interchanging those two terms now, and they're not at all the same. We do see some people who have terrible things happen to them, and not only do they bounce back, but they actually bounce back better than they were before. You've likely heard people say that. You know, and my own wife, who had breast cancer, says, breast cancer, though I would never ask for it, turned out to be an incredible gift for me because it helped me reframe my priorities in my life. But that's not the case for most people. Most people, when they have bad things happen to them, they're devastated. And many of them never bounce back again. So assuming that somehow being resilient is good enough is a false way to think. So the other way I like to frame this is to begin to think about this in the context of two main areas that I think need to be focused on if we're going to begin to do something about this. The first is what I call the operational side of this problem. And this gets into things like regulatory burden, gets into things like administrative hassles, process inefficiencies, technological challenges and shortcomings. Those are all the operational pieces of what many may call the hassle factor of what we're doing. And what we do know is that's getting more and more in terms of the work that we do. It's very different than it was 10 years ago. And it's relentless, and it doesn't seem to be going away. Very important that we address the operational components of this. And a lot of folks nationally, that's where they're spending a lot of time. And I would contend that we have to do that, certainly to get out of burnout. But I would also contend in order to get to thriving, it's not just about being efficient. Okay? It's not just about lack of hassles. In order to get to thriving, we need to get to the core of why we do what we do in the first place. And that's about relationships. That's about, first of all, how we work together. How connected are we? How do we communicate together? How are we as colleagues around each other? And it also gets into our own self-care. How do we, in the midst of all these challenges, actually take care of ourselves? What are we doing to make sure that we have time to emotionally recover from the distress of our work in downtime? So relational becomes important. And I also believe that it's going to be vital for us to do some deep work to say, let's get back to why are we doing this in the first place? Getting back to meaning. Getting back to what does it mean to have a professional identity? What does it mean to be a professional, truly? So that we don't just think this is a job. We don't just begin thinking this is just something I punch in and do, because that's, first of all, that's not our history. That's not the history of this profession. And secondly, it's not going to allow us to do the kind of work that many of us dreamt that we wanted to do and wrote on our admissions essay to medical school that was the kind of person we wanted to be, and this is the kind of work that we wanted to do. And around that, we need to do two things, I believe. One is that we need to look at our culture and say, what kind of culture have we created both locally and nationally that we are swimming in? What kind of oxygen are we breathing right now? And how is that helping us advance our own well-being? And secondly, looking at leadership. There's some studies that have looked at the impact of leadership on well-being and burnout, and it's very real. So how can we, as leaders, begin to take ownership for some of this and create the kind of cultures and create the kind of operational issues and create the kind of relational connections and anchor ourselves in meaning and identity so that we can begin to advance our well-being work? Our Faculty Vitality and Professional Wellbeing Committee believes there are 4 main areas that we want to focus on as we begin this work together. The first is looking at well-being, burnout, and burnout education and skills development. That there are some skills that we need to develop. Okay, there's some things that we really don't have that are going to get us where we need to go. The second thing is crisis management and prevention. I'm going to come back to each of these in just a moment. The third is what I call fourth aim, continuous improvement. How do we begin to identify those pain points for us and begin addressing them in a very systematic and deliberate fashion? And finally, culture and connection. How do we begin to create the kind of culture and the kind of professional connection we really want to have with each other? So let's break this down. First thing I believe is that everybody sitting in this room is a leader. You may not have a title, okay? You may not look at yourselves that way, but here's why I say that. I say that because those who work with you are looking to you for leadership. So I would contend the question is not whether you're a leader or not. The only question is whether you're an effective leader or not. So I want to lay out that challenge for you this morning so you can take ownership not only for your own stuff, but for our collective group as well. Second thing I want you to remember is that every system is perfectly designed to get the results that it gets. So if we have a system that's designed that's not getting us where we want to go, we're going to have to do something. We're going to have to begin to think about this differently and do something about it differently. So how do we tame it? Well-being and burnout education and skills building. Here's some things that are going on right now in the system in a systematic way to try to address this. First of all, we have a committee. And as I shared earlier, we're trying to create this as a representative committee. The purpose of this committee is not to centralize this process. The purpose of this committee is to start communicating and connecting and networking across all our different departments and all our different matrices within the organization to begin to advance this work. There are pockets of really good work going on already in this organization. We need to figure out how to get those to other places. There are ideas that are happening both locally and nationally. We need to figure out how to tap into those more effectively. We're starting to use this fourth aim language. Our CMO, Patrice Weiss, was one of the first national leaders I heard standing up and saying, we are about the quadruple aim, not just the triple aim. And when she did that 3 years ago, it took a lot of courage to do that because not many people were doing it. And a lot of people were eye-rolling at this whole idea of the fourth aim. And she believes that deeply. And our CEO believes that deeply. I was in conversation with her as recently as this week talking about this very thing. That's good news. So we have some people in leadership who believe strongly, not just in theory about this, but in practice. Connection around quality, safety, and risk. John Gleason and I have had multiple conversations about how we can begin to connect this work to our quality and safety work in the organization, because it is impacting the quality and safety of the work that we do, and we have to figure out how we can begin to do that differently. Department-specific activities and committees. Many departments are also beginning to form their own committees and saying, okay, we know that there's an organizational committee, but we want to begin to address this even within our own group or within our own section. How can we do that better? System and departmental surveys. As I shared, we've already done one. In family and community medicine, we've already done a follow-up survey looking at how we've moved the needle over the year since we did our first survey in 2016. I'm happy to say that even with what I would consider just the early changes that we implemented in our department, we dropped our own departmental high risk for burnout rate for our physicians by over 10%, and for our ACPs by over 25%. Started at 61% for each of them. And so what I know is we can move the needle, and I don't think that's an aberration because I'm seeing it in terms of the faces of people that I work with. I'm hearing it from our colleagues out in practice, that they feel like the change has happened. The culture within our department is starting to be different, and they're starting to feel appreciated and supported in ways that they weren't before. Website resources. We're about to roll out a website, hopefully in the next month or two, with resources on there, so you can go there and begin seeing what's available for you, particularly if you're feeling like you need help in this or you just want to learn more. Carillion Wellness is about to roll out something next month called Virgin Pulse, which is to look at our physical well-being and beginning to systematically say, how can we do that in different ways? Schwartz Rounds is a way for us to begin to get compassion with each other and raise our awareness of how we're doing with compassion. And talking about it becomes vitally important. Crisis management and prevention. What are some things that we're doing here now? First thing is to understand that our EAP program here is an important part of the work that we do. The challenge that we have as physicians, particularly, is that many of us say, I would never access EAP. Many of us, even though we're employed, don't think of ourselves as employees. What I want to invite you to do is to consider, if I need help, EAP is a place that I can go. EAP is separate completely from Epic, completely separate from all those things. So confidentiality is real. So think about that. We know we have some colleagues who are already accessing that. There are other resources as well, other counseling resources. Some of our colleagues say, I'm just not comfortable with that. EAP feels too tied to the organization. And if that's the case, some of them have gone out and sought out private counseling as well. The key with that is if you feel like you need help, please do it. Please ask for it. That becomes the important step for many of us in terms of breaking down some of our socialization. A lot of healthcare resources. If you don't have a physician or a healthcare provider, please get one. Don't wait. We have some of our residents who wait until a crisis happens, and at that point, often, that's not the time you want to start developing a relationship with your healthcare provider. So get one. Trust team. We have a second victim team here, and hopefully some of you have had the opportunity to have them reach out to you because of an adverse event that's happened on the wards. The trust team is there to be proactive, to say when some bad outcome happens, we know that people are going to be emotionally impacted by that. Rather than waiting to see whether that happens, we're going to be proactive and reach out and just say, we know this happened. We want you to know that we care, and if you need help, help is available. And as part of that, we have some peer support. And so if any of you are interested in being clinician peer supporters for some of your colleagues who are distressed, please let myself know, or Christy Wills, who's here as our manager of our faculty vitality and physician leadership, let us know, and we can get you that training. We want to make sure that we have the resources available. Crisis hotlines. We're working to make sure that crisis hotline is readily available for you if you should need it, so that we never have to tell the story that many organizations are having to tell of physicians and others who chose to take their own lives because they felt like there was no other way to address the distress that they were feeling. And website resources we've talked about. And finally, once again, talking about it. I find it's incredibly disarming if you're feeling distress to share that with a colleague and start to talk about it so you don't feel like you're alone. Very vital. Fourth thing, continuous improvement. This is a very simple idea. We did it in our department. It was incredibly powerful. Do surveys. Ask people, what are the 3 things that are most stressful or most draining for you? What are your pain points? What is just killing you right now in terms of hassle? Collate the data. Talk about it. We talked about it in family medicine or with our leadership group, and we started making a plan. Not surprising for us in family medicine, the top 3, electronic health record, electronic health record, electronic health record. Okay? And what we said is, you know what? That's showing up too often. It means we're not moving the needle on it. And so we became very deliberate about doing that. We decided that we were going to get much more involved rather than looking just to our TSG colleagues to help us with that we needed to solve that ourselves as well in collaboration with them. One of the things that we found was something called a PEP report that many were not even aware existed. PEP report stands for the Provider Efficiency Profile. And it basically allowed us to see how each individual clinician was doing on Epic based on some parameters that Epic had sent out. And we found that some of our clinicians, not surprisingly, were flailing using the instrument. Now, I won't say that Epic is the best thing that ever happened in my life, okay? But Epic is a tool. And what we're finding is that many of us are so far underutilizing the tool that we have, that's what's hurting us. So what I tell our clinicians is my goal is not to make you love Epic. My goal is to neutralize it, is to make it so that it is a useful tool for you, that you can get your work done in a way that it doesn't interfere with the rest of your life. And we've done some incredible things around that, just with something as simple as voice recognition software and dictating into that voice recognition software rather than trying to painfully keyboard a lot of our data information. So there are ways to begin to do that. The purpose of our committee is to begin to spread that across the organization. And then what do? As soon as we start moving the needle, we come back again and say, what's the next thing? What's hurting you now? What's the pain point now? And we keep doing that over and over again. Finally, tame it by culture by design. This community and culture. This is the idea of saying, begin to ask the question, what kind of place do I want to work in? What kind of an environment do I want to work in? How do I want to be with the people around me? And how can we begin doing that in a more deliberate fashion? Culture is basically the way things are around here. The best way to find out about what your culture is to have somebody new come into it and ask them, what's our culture like? And they'll tell you. They'll say, this is exactly how you are. This is how you interact with each other. This is what's important to you. This is what's not important to you. This is how you handle conflict. And you start to get an idea about that. And as we raise that into conscious awareness, we can start doing something about this. Here's what we know about culture. This was a study that was done in 2005. It's a study. Don't get lost in the numbers because it basically asks what factors make doctors, because that was the question they asked at that time, more satisfied. And it was real simple. And we all know it, but we forget it. It's about relationships. Relationships with patients, relationships with colleagues, which is something I think we often neglect, relationships with loved ones, and our relationship with ourselves. How do we take care and care for ourselves? The other thing that's important to remember in terms of creating a thriving culture is that there's some science around hassles and uplifts. Here's what we know about the negative in our lives. The negative sticks to us like Velcro. Think about a day in your life. Okay, I'll use me as an example. I can go through a day and have a great clinic, great rounds on the wards, whatever that might be, and I can have one bad thing happen. I can have one patient complain about something, and you know what I'm thinking about that night? That one thing. I'm not remembering all those incredible things that happened, all those lives I positively impacted. I'm remembering that one negative thing. So we have to understand we're wired that way. We're wired that way as humans, and we're wired that way as clinicians as well. And so in order to overcome that, data says that you have to have 3 uplifts for every hassle in order to have a neutral emotional bank account or a balanced emotional bank account. Now consider an intimate relationship that you have. Okay? Do you have 3 uplifts for every hassle in that relationship? If you don't, there's your one highlight and insight to take home with you today. All right? You start doing that and watch any culture change as you create more encouragement, more enthusiasm in that culture to overcome the fact that hassles are going to happen. They're not going away. So what would it take? What would it take? Say, I love my work. Or perhaps even more importantly, I love my life. Hopefully, this morning, if nothing else, has planted some of those seeds of possibility that I talked about earlier. Hopefully, for some of you who are feeling burned out right now or feeling like you're in the grind of survival mode and you don't see any way out, that we've shown some light for you. Hopefully, for those of you who are thriving or are doing quite well, you've been challenged to say, first of all, keep doing what I'm doing. But secondly, to begin to look around at your colleagues and say, how can I help uplift others going on? Because the goal at the end of the day is not survival. The goal is not to grind through this and get to this magical place called retirement. The goal is to find thriving and meaning and fulfillment and connection in our work right now, today. And so what I want to ask you to do is, based on what we've talked about this morning, what's one change just that you can reflect on today that you could begin doing differently that would begin advancing you along that continuum from burnout, survival, fine, well, toward thriving?